go forward.
Okay, sir. Okay.
Pawan, on your count.
Yeah.
So we're good to go.
Yeah, good evening, friends. I'm Dr. Kaladhar, Senior Consultant Critical Care Medicine from Yashoda Hospitals. Welcome to our master class from the Department of Critical Care Medicine, Yashoda Hospitals. We conduct these sessions every Tuesday. So in the master class, the students come forward to present live case scenarios. Along with that, senior seasoned examiners are involved, where they share their expertise and guide the students. Over a period, almost since 3 years, these sessions been conducted. Most of the students' feedback are that they are very much helpful for regular their practice and even especially during exams, help a lot. So, Dr. Venkatraman Kola sir is his brainchild is the master class actually, and he pushes us forward. And today's topic for discussion is AIDP, GBS, and FLACCID paralysis. For this, I welcome our senior seasoned examiners, Dr. Rajesh Misra sir. He is our past president, national past president of ISCCM, very well known, very active and enthusiastic. His energy is contaminating to everyone, I can say, because I had seen his sessions in different forums and was definitely motivated with that. And he is honorary consultant intensivist, internist, and sleep medicine, Shaibya Comprehensive Care Clinic from Ahmedabad. I welcome Dr. Kapil Borawake sir. He is the senior consultant, director of Department of Critical Care Medicine, Sahyadri Superspeciality Hospital, Arnab, Pune. I welcome you both of you on board, sir.
Yeah, sir, it's our pleasure and honor, sir, Rajesh Misra, sir, to give your valuable time and share your knowledge with our student. It is an honor for us. Thank you very much to be a part of it, sir.
Thank you. Thank you, Venkat.
Present to today's. Yeah, thank you, sir.
And thank you, Kapil Borawake, sir, to give us the scheduled time. Thank you for being with us. Over to you, Kaladhar, for the student.
Yeah,
Pleasure.
we have two of students, Dr. Arnab and Dr. Prithwiraj. Both are from Fortis Escort Art Institute from Delhi. They are going to present this case. Dr. Arnab, yeah, you can go forward.
Good evening, sir. So just going with today's presentation. Sir, we had a 18 years old female presented with chief complaints of gradual onset weakness in all 4 extremity since last 4 days, and drowsiness since last 6 hours, and cough for last 2 days. History of present illness. Patient was all right 4 days before when she developed weakness in her bilateral lower extremities since 6 a.m. in the morning. The weakness was ascending in nature with subsequent weakness of bilateral upper limb also since last 2 days without weakness of eyelids. The weakness was more in the lower limbs compared to the upper limbs. The weakness gradually increased in nature and she felt difficulty in standing up from sitting position and difficulty in lifting weights, which was previously normal for her. Weakness was similar throughout the day without any progression with activity. She noticed gradual difficulty in buttoning and unbuttoning of her dress and hair combing and slipping of slippers from her feet. Gradually, her weakness increased in all 4 limbs, and at present, she is almost bedridden. She was unable to speak since last 1 day, so history was given by her parents. No history of diarrhea, fever, abdominal pain, any drug intoxication history was given. No history of any seizure or loss of consciousness or memory impairment or no pain in her body. No history of any fall, no history of any trauma, no history of injury to head or spine, no travel history, no particular sensory level described by family, no bowel or bladder involvement, no history of any insect bite, no other comorbidity except she is a known case of bronchial asthma for which she takes home nebulizer formoterol 0.5 mg SOS. Can I proceed to next slide, sir?
For a moment, can you go to back slide?
Yes, sir.
Gradual onset weakness in all 4 extremities since last 4 days. In
Yes, sir.
all four extremity together, or it started lower first and then progressed to upper?
So, as I said in this slide, it was initially in the lower limbs for last 4 days and upper limbs for last 2 days. So it is gradually progressing from lower limbs to upper limbs.
So then that's what the difference illustrated. But when you say that here should be very clearly said that weakness started gradual onset weakness in lower limb and going to up in last 4 days. Because the
Yes,
moment this sentence reflect that is 4 days. Why this patient is
Okay, sir.
drowsy?
Actually,
Why is this patient is drowsy for last 6 hours?
sir, that history, sir, actually we evaluate subsequently, sir.
Oh,
It
okay.
was due to CO2 narcosis, sir. Actually, we
Okay, that's it.
evaluated later on, sir. Yes, sir.
And cough, what is the significance of cough here?
Sir, basically, she was not able to speak, and her cough reflex was also, she was having symptoms of bulbar palsy also, I will say subsequently. For that, we were suspecting some aspiration pneumonia. For that, she was having some cough. I will go into those histories, sir, with the subsequent slides.
Okay, please go ahead.
In past history, there was no similar complaint in the past.
Can I just ask you?
Yes, sir.
There are two things I would like to ask you. One is you have specifically asked about uh, the weakness which was gradually progressive throughout the day, or whether it was changing with your repetition of activities. Can you elaborate me what you want to actually, what is your reason for asking this? What do you want to exclude?
Yes, sir. I actually wanted to exclude myasthenia, symptoms of myasthenia gravis with this, because with fatigue, myasthenia gravis, sir, typically presents with fatigability. So initially in the early morning, when the patient wakes up, he or she may feel some weakness, but it will be not that much great. And with activities, as she gets tired, the weakness subsequently increases with activities or as the day progresses. So myasthenia gravis, sir, typically gives this kind of history. So I wanted to exclude the history of myasthenia gravis by that history, sir.
Any other particular symptoms you would like to ask about, if you want to differentiate between UMN sign and LMN signs?
Yes, sir. Actually, I asked because there is any history of spasticity, or there is any history of clonus in the body, abnormal movement in the body was there or not. So, or whether it was the paralysis was kind of flaccid paralysis kind of history. So, with that, I can differentiate between UMN and LMN palsy, sir.
Yeah, any particular insect you would like to? You have written about
Sir,
insect.
insect tick bites, sir, can present like this kind of history. Lyme disease can present like this kind of history. Snake bite, paralytic snake bite also can present with this kind of history, sir.
And one more thing which is worrying me, that why family being there for so long in the house, or whether she was treated somewhere, because 4 days till she developed breathlessness or
Actually, sir, because the history subsequently was initially the weakness was not that great. It progressed subsequently with 4 days. So when she was drowsy and weakness of bilateral lower limbs and upper limb also and she became drowsy. So then some alarming features arised in mind of family, and they brought the patient to hospital. And the socioeconomic status was also not great, so they were not very aware of the situation, what was happening with the girl. So that's why they did some delay of around 3 to 4 days to bringing her to hospital. And this was her first patient incident, sir. She wasn't admitted to any other hospital. She came from home.
and there was no pain involved. She never complained of pain.
Yes, sir. No, sir. There was no complaint of pain in anywhere of her body. No history of any sharp demarcation or any sensory demarcation also.
Okay, whether that gives you some clue about any, to narrow down your spectrum of the disease,
Yes,
that there
sir.
was no pain.
Yes, sir. Yes, sir. Acute transverse myelitis can present with a sharp demarcation, and it is also an autoimmune disease which can present like similar complaint.
Okay,
There is a
because
garden-like sensation in transverse myelitis, a sharp sensory garden-like sensation with dermatome, sir. A patient can present with such kind of history.
okay, okay, fine.
Can I proceed, sir?
Yeah.
With the past history, sir, there was no similar complaint in the past, no known comorbidity, and no history of any recent immunization. In personal family, uh, in personal history, bowel bladder was normal, last bowel movement 2 times a day, and normal in color. Urine output was adequate, yellowish according to family. Diet, mixed diet, veg and non-veg both, no such significant family history. Can I proceed, sir?
Yeah. What is the disease called, which is if it is associated with vaccines? Any particular vaccine you mean to say, and what is that entity called?
Sir, periodic paralysis can present with vaccine waning features, or sometimes a disease like multiple sclerosis can present with vaccine waning or with any triggering. Sorry. Vaccine. Oh, sorry, sir. Sorry. I thought vaccine. Vaccine, sir. Vaccination. It is some history of, sir, influenza post-influenza vaccine has been studied with association with GBS syndrome, and also COVID. Post-COVID also we have seen some cases of GBS also. Other hepatitis also, sir, but other diseases, some case studies were there, but no specific correlation was found with any other kind of history. And in past, sir, with vaccines which are prepared, rabies vaccines which are prepared in nerve tissues, in past, not in recent times, there was history of some GBS when the vaccine was prepared in nerve tissues in rabies.
Any timeline for vaccine? Like suppose I've taken vaccine before 3 months.
4 to 8 weeks.
I didn't get what was the timeline.
4 to 8 weeks generally, the preceding event of GBS. For GBS, sir, it is 4 to 8 weeks, what I can remember, sir.
Yeah. Maximum is as per WHO, it is up to 6 weeks. All the guidelines. If you have got vaccination, which is done within 6 weeks of time, usually you can correlate that acute inflammatory polyneuropathy to the vaccine. But if it is beyond 6 weeks, I think then we can exclude.
Okay, sir. Okay, sir. Okay.
Yeah, you can proceed.
Okay, sir. Coming to general examination, sir, patient was drowsy, arousable but unable to speak. Her GCS was E3, V5, and M1.
Just
Sorry,
wait,
sir.
just wait for a moment. Just wait for a moment. Why did you assess GCS in this patient?
Sir, sorry, sir.
Why did you assess GCS in this patient?
Sir, as a part of general neurological examination.
Actually, we should assess GCS in trauma patient, but we in our daily to daily practice, sir, we assess GCS. So can you assess? The next question is: should you assess? Can you assess GCS in this patient?
Sir, she is unable to speak, so I cannot assess the verbal.
I'm just asking a question. Reply me yes or no. Can you assess GCS in this patient, or should you
No,
assess
sir.
GCS? Yeah, no. Yes or no.
No, sir. No.
So just remember that whenever there is a peripheral problem, GCS is not mean to that. Unless you expect somebody has central neurological insult that is affecting GCS, then only you should try to assess GCS. So if you write GCS, your examination goes in wrong thing. In this class of patient, you cannot assess GCS and you should not. That's why you should not even mention it.
Okay, sir.
But you should be knowing
Okay,
it
sir.
clearly. The GCS, when you are not mentioning, somebody asks why you are not assessing GCS, they should be able to tell it.
Okay, sir. Okay, sir. Okay.
You might be doing correct as a general part of examination, but somebody like me, that means you don't understand GCS properly, because you need to know that when you are using some tool, you are using at right place or not. So you cannot use GCS in this kind of thing.
Okay, sir. Her build is sir moderately built.
Somebody is asking, can you repeat what I told you about GCS? Somebody is asking in chat box to repeat GCS. Can you repeat the thing? By Kaladhar, please keep on seeing the chat box. So something important
sir, sir.
so we can reply.
Yes, sir. Yes, sir. Okay.
Somebody is asking. Arnab, somebody is asking
Ye-
about GCS.
yes, sir.
Told
Yes,
you.
sir. Yes,
Can
sir.
you repeat the
GCS.
sentence?
Yes, sir. In this kind of patient, we cannot assess the GCS. GCS is made for trauma patient with brain injury. So GCS is not a proper tool to be examined in such patients, sir. It is not an appropriate tool in this kind of patients.
Not
for this
only
kind of
trauma,
patients.
not only trauma, even for the progress of any CNS insult, the brain injury, it is a tool, but not tool to assess the peripheral injury. So you cannot like assess GCS in a patient who did not have central injury. So that's
Right,
important.
sir. Okay, sir. Sorry, sir.
No,
Can I
sorry.
proceed?
Just pointing out some small unnecessary.
Yes,
Somebody tried to pull your leg on something which you have done correct
Yes, sir.
from your part. So
Yes, sir. Can I proceed, sir?
yeah, please go ahead.
Her build was moderately built. Pallor, clubbing, cyanosis, and icterus were absent. Coming to vitals, her pulse rate was around 112 per minute, regular, and regular in both upper arms. No radial or radiofemoral delay. BP is 102 by 59 millimeter of mercury, and her saturation was 93% on nasal prong at 4 liters per minute, and temperature was 99.8 degree Fahrenheit, and her blood sugar levels RBS was 18 milligram per DL.
So what does the general examination indicate?
So the general examination indicates that she is having some alteration in mental status. She is drowsy, so there might be some central cause related to this pathology. Uh, and also, sir, she's having a tachycardia, and her saturation is also low, requiring oxygen. She's in requirement of oxygen. So some lung pathology or something. Yes, sir.
So in view of gradually progressive quadriparesis, which is predominantly neurological, which is gradually progressive motor, not motor weakness, not sensory, with signs of tachycardia and with signs of hypoxia. What does it indicate? And with signs of drowsiness? What is the inference?
Sir, inference is she's hypoventilating.
Okay.
One thing is that hyperventilating, and said there is involvement of the respiratory muscle.
So did you check cough reflex here in this patient at this time?
In the neurological examination we have done, sir.
That is more important than giving GCS. If patient is drowsy, is he able to cough or not?
Okay, sir.
What kind of cough you are going to get in this patient? Why cough reflex is important?
Because, sir, that is important, sir, to assess whether there is a bulbar involvement.
Whether sir, she is able to protect her upper airway, or whether risk of aspiration is there or not.
Why?
Or, yes, sir.
Why?
Involvement of cranial nerves.
Then what
Bulbar
will
palsy.
Yeah, bulbar palsy. So
Yes, sir.
if it's a bulbar palsy, what kind of cough? What will happen to cough?
She will be cough reflex will be, sir, depressed. She will be not able to.
And why is he has hypoxia, low oxygen?
Sir, respiratory muscle weakness.
What it will cause? Why hypoxia? Respiratory muscle weakness. There are a lot of patients which are having respiratory muscle weakness, but they do not get hypoxic. Why this patient will be hypoxic?
And sir, if the patient has aspirated her secretions, might be there is some feature of aspiration pneumonia which causing the hypoxia, sir.
No. that is a very remote possibility by the time she will get intubated. Why the dengue patient with respiratory muscle weakness will have hypoxia? Sorry, GBS syndrome. Why the GBS syndrome with respiratory muscle weakness will have hypoxia?
There will be diaphragmatic involvement, matlab respiratory muscle involvement for which
Always,
we cannot.
always remember that GBS syndrome doesn't involve involuntary muscle. It involves only voluntary muscle. Diaphragm never get involved in GBS syndrome. So why this patient will have tachycardia?
Autonomic dysfunction, sir. One, sir, due to the anxiety of the patient, which is very common because in an 18-year-old adult is going with a weakness of all the four limbs. This is one most
So
important cause.
what happens when you have respiratory muscle weakness due to the GB syndrome? You are not able to generate enough negative pressure to breathe in, and
Yes,
that
sir.
leads to the atelectasis. Very commonly, this leads to huge basal lungs start collapsing and getting atelectatic. That will cause hypoxia to begin with, and then hypercarbia later. Already your patient is drowsy, and based on
Yes, sir.
that, probably person has been not. I think before that, patient will have poor cough reflex, so he will not able to cough properly. So combination of poor cough reflex, not able to breathe in properly, basal atelectasis, leading to hypoxia and hypercarbia both. A patient is drowsy, but then means he is first. But these patients first retain CO2, later on they become hypoxic. You can give oxygen, but it's not a good sign that somebody is with cough, poor cough reflex, getting hypoxic. You are still waiting. So this kind of patient, if they have poor cough control, should be intubated early rather than trying with NIB. Because even if you try with NIB, NIB may not able to help you, and the patient may arrest. So no need to fool around for. So one of the commonest mistake done in this kind of patient, they are put on NIB looking to the hypercarbia with poor cough reflex. Sometimes you feel partially getting better and suddenly these patients arrest. So if GBS syndrome
Yes,
is
sir.
rapidly progressing, cough reflex is bad, better to protect airway and ventilate them, because that will prevent you from going to a lot of complication. And these patients' chance of arrest is high because along with neuropathy, they develop autonomic dysfunction very fast. That's why they become tachycardic, sweating, tachypneic. So all these are sign of autonomic failure and motor failure. By the way, why do you
Yes.
keep myasthenia as a differential diagnosis of GB syndrome?
So myasthenia was a remote possibility, sir. It was we were almost sure that this is
Until unless GB syndrome is presenting atypically with pharyngeal muscle
yes,
weakness,
sir. Yes, sir.
chances of myasthenia is absolutely different spectrum. Is a
Yes, sir.
more
Yes, sir.
of the disease of mix both voluntary and involuntary muscle involved with deglutition and eye nerve. Until myasthenia comes in disease of the snake poisoning, botulism, and all these things.
Yes, sir.
But when it's a progressive, when it's a gradually progressive motor weakness starting from lower limb, first, second, third is only AIDP. The second possibility is the transverse myelitis, but transverse myelitis will always be having, always say only motor is rare. Somehow sensory and bladder bowel will get involved, which is not there in GB syndrome. Then third comes some acute toxin poisoning, something like that. So it's like that. So very classical history, rapidly progressing, predominant motor weakness. 1 to 10 is AIDP. You can keep all this, but when you keep a differential diagnosis, should be very, very clear that what is the differentiating point from AIDP to the any of those DD which you have said. Okay, go ahead, please.
Can I ask? Can I ask?
Yeah, yeah.
Yes,
Why
sir.
not?
Yes, sir.
Kapil? You should ask.
Please, sir. Yeah.
Somebody in the chat box I also asked this question: what is 20-30-40 rule for GBS? And regarding that, the same question for this patient, you have decided to give mask by oxygen. On what basis that you have decided that you will give oxygen and you will not intubate this patient? What was your
Sir,
thought?
this is the no, sir. This is patient presented to ER. We just went to see the patient. This is the
Okay.
just our point of contact, sir. We haven't started our examination yet. So this is the point of contact when we saw the patient in ER, sir. At that time, it was kept like that. Then, sir, we started intervening with the patient.
Okay, okay, fine. So you have to yet to assess.
Yes, sir.
But
We are just assessing. Just we arrived at the ER at this point, sir.
so
No,
suppose
that's why I said in ER only. Suppose you are only giving oxygen, patient getting drowsy, so bit tachycardia, so you should be coming to action also, because what happened, we should not allow the patient to get arrest.
Right, sir.
Okay.
Right, sir. We intubated the patient as soon as possible,
Yeah,
sir.
please go ahead. I just gave you the inference. This is the commonest mistake done. So when you are telling, so like the difference between presenting your case to as a MD medicine person or as a MBBS, and here when you present your case, you should not be typically presenting like what you used to do in MBBS or MD. Here you should not be showing those things which you don't do. So like that's why I tried to get to channelize
Yes,
that
sir.
whatever you say, each and every word should have a meaning. You cannot say anything just
Yes, sir.
like that. I caught up you at GCS, I caught up you here. The only reason is you have to be very specific in saying he was on oxygen with poor cough reflex, needed to be intubated quickly, or he was intubated. So he was on oxygen, drowsy, so poor cough reflex, intubated. I will not ask any more question. But if you talk like the typical MBBS case presentation, then you will be pulled up further.
Okay, sir.
yeah, any other possibility you think of? Any remote possibility? Any other disease, tachycardia, hypotension, desaturation, very typical in critical care settings. Hypotension, tachycardia, hypoxia. What you should never forget as an intensivist?
Sir, only regarding, sir, with this all four limb weakness.
No, anybody, I'll say anybody coming with these three symptoms: hypoxia, hypotension, tachycardia.
As septic shock, say sepsis, infection, or
Chat box
ARDS means any type of infection, sir, we have to rule out. And
Beyond
also symptoms of heart, acute coronary symptoms that also present with this type of hypotension, tachycardia, and hypoxia.
See, as an intensive care specialist, whenever I see hypotension, tachycardia, and hypoxia, I will only think about pulmonary embolism.
Pulmonary embolism.
Not in
Yes.
this case, but this should always click to us all the time.
Yes,
We have never asked her long travel history. This is not related to the case, but that should stick to your mind all the time. Without that, you will miss it.
Can you just go
Yes.
back and just sorry, can you go back to the history, detail history? Detail. Go back.
Yes, sir.
Have you taken two history of fever in last 10 days and history of heavy meal previous night before weakness?
Yes,
And
sir. Yes, sir.
it is there?
History of fever, sir. There was no history of fever, sir. I have mentioned no history of diarrhea, fever, abdominal pain,
Fever,
in
upper
intoxication
respiratory
history.
fever and URTI. Fever,
Yes, sir.
fever, acute gastroenteritis, and upper respiratory
Hmm.
infection.
Yes, sir.
You have not mentioned this here.
Sir, fever I have mentioned, sir. In no history of diarrhea, fever, abdominal pain. In that line, sir, I have mentioned here.
Okay.
Yes, sir.
Abdominal pain also there is no history.
Yes, sir. Abdominal pain I have mentioned. No history, sir.
What is the significance of abdominal pain with GBS syndrome?
Sir, patient can
And
present with
which type of abdominal pain
pain.
especially? Which type of abdominal pain can especially lead to GB syndrome? I think it will be
Sir,
difficult.
crampy.
I'll just tell
Sir,
just add to
Campylobacter
the,
jejuni.
yeah.
Yes, sir.
No.
Sir, Campylobacter jejuni.
So of late it has been found,
Hepatitis.
of late it has been found that a lot of patients who come to GBS syndrome and do not have any preceding illness, if you do upper GI scopy, they found to have very heavy infested with H. pylori. And there is a
Yes,
very
sir.
significant history of H. pylori with GB syndrome. So just you can
Yes.
add to your checklist of checking the H. pylori with GB syndrome. So and H. pylori has been directly implicated to cause GB syndrome, motor neuropathy. So add in the list of upper particularly severe gastritis or chronic gastritis or acute gastritis can contribute. And a history of heavy meal and thyroid dysfunction. Why it is
Yes, sir.
significant? Why it is significant?
Hypokalemic, sir.
Hypokalemic periodic paralysis, sir.
So
Yeah.
especially high-rich carbohydrate diet, sir.
Yeah.
High-rich carbohydrate diet will present with high insulin secretion and will cause a hypokalemic periodic paralysis.
Perfect. Perfect. Okay. Go ahead. Go ahead, please.
And sir, with the abdominal pain, basically, I wanted to rule out acute porphyria.
And that again, acute porphyria is a typical disease of acute abdomen. It's not a disease of distal neuropathy leading to proximal, rather than it's a more, if there is at all weakness, it's a more of the proximal weakness. Acute porphyria is an emergency which typically present with acute abdomen with more of the proximal weakness and more of the neurological symptom, not typical of the muscular symptom. You can keep it a possibility, but again,
Yes, sir.
again, your discussion will get diverted. So I know one of the tips for being good student is keeping your possibility limited and focus. If you try to open the Pandora box, your discussion will go to the acute porphyria, and I'm sure that you will not be able to answer even 3 questions on porphyria because not a routine thing you do see. So don't try to get into trap up something which you don't do routinely. Keep your discussion limited to which you do commonly and which you are expert at. Don't try to give lead examiner to ask something which you are very weak.
Okay, sir.
Go ahead, please. Next.
Sir, in systemic examination, as we have done the CNS examination first, in inspection, our patient was drowsy but arousable. Patient could not move any of the 4 limbs. She could not even move her neck. She was communicating with her eye movement, vertical eye movement for yes, and horizontal movement for no. There was no scar marks, no sign of trauma or any bite marks present. In palpation, sir, the tone is flaccid in nature. Neck rigidity was absent, no spinal tenderness. We have assessed the motor power. The power was 0/5 in bilateral, all 4 limbs. And sensory was superficial, touch, pin temperature was intact. And deep, like joint sense, position sense, and vibration sense were also intact. Our MRC score was less than 20. And superficial abdominal reflexes was normal, plantar reflexes were equivocal, and deep tendon reflexes were absent. Gait could not be tested, sir. Shall I proceed, sir?
Yeah.
In cranial nerve examination,
Just
gag reflex.
sorry, just go back. So rather than doing so much of the things, why can't we be very specific on inspection and palpation? So till now, you have reached to a diagnosis that you are dealing with a rapidly progressing motor weakness, preferably polyneuropathy, because a peripheral thing, not central involved, preferably nerve involvement. So what is the specific thing you need to look at inspection and palpation?
Sir, we need to, in inspection, we need to see whether any signs of fasciculation is there or not. Typically, we want to see for lower motor nerve lesions. And whether any bite marks there or not for any insect bite or any history of trauma.
Let us talk to the positive. If you are thinking, your thinking is clear, it's the most likely AIDP diagnosis. What inspection finding you really need to look to that? Very specific.
Sir, the Sir, flaccid paralysis,
I cannot see.
symmetric flaccid paralysis, sir.
So you ask the patient to move the limb, move the eye, and talk and cough.
Yes, sir. Yes, sir.
And this is all you need to quickly look to that. Definitely, if you can lift the neck and all this thing, very specific. And what you need to do
Yes.
in palpation, you need to assess the motor power.
Yes, sir. Power and tone.
And the reflexes, sir.
So according to you, motor power is 0/5 in bilateral limb.
Yes, sir.
No flickering movement, nothing.
No, sir.
And what about respiratory muscle? Anything about respiratory muscle in inspection and palpation?
So, the withdrawing of chest during the respiration, that we should look into in the inspection.
Have you written?
No, sir.
And what is the strength of his head? Can he press your head? What is the weakness? What is the grade of weakness in his neck area? Can he do his head press test?
No, sir. She is not able to move her neck against gravity or without
Is this patient
against resistance.
is this patient intubated or not intubated?
Yes, intubated, sir. Intubated. We
So first
intubated in the emergency only, sir.
First thing you should write, you are examining an intubated patient in emergency.
Yes, sir. We intubated the patient, sir. Actually, after
But you have
examination, we
not
intubated
written.
the
How
patient.
do I know? How do I know? I don't know. When you are
Sir, in,
look,
sir,
when you-
here, sir.
no.
Patient was intubated in
this is
ear
a-
in view of drowsiness.
No. This is coming later. I'm talking about inspection. Should not you mention that inspection that you are because of this thing we have intubated and then we are talking about the inspection finding in intubated patient.
Sir, what we are saying at
By the moment you tell about me, I will think like intensivist. Though I am a physician, I will think like intensivist. Are you telling me a dead patient or live patient? Somebody quadriplegic, no cough reflex, nothing. If you are examining this patient, is this patient alive or not?
Yes, sir. Actually, just we completed the examination and we immediately intubated the patient, sir.
So that is also not correct. That's where you are different from being physician or being anesthetist or being any specialist. As an intensivist, your first priority is to save the patient. As an intensivist, you are supposed to first keep the patient alive, then you can examine. Is a respiratory, your patient is retaining CO2 on clinical ground. Your patient is hypoxic. Your patient has respiratory muscle weakness. You did not mention about any sign of respiratory muscle weakness, like using extra respiratory muscle, intercostal recession. You did not mention about that. You did not mention about the respiratory rate, what it is. When somebody presenting with GBS with respiratory failure, your focus is only on GBS. Your patient is much more advanced. It's not a simple GB syndrome. You are dealing with rapidly progressing GB syndrome with respiratory complication, which has different implication in managing simple GB syndrome.
Yes, sir.
Are you understanding my point?
Yes, sir. Yes, sir.
we should have written before
So
this.
you are writing what happened? You have a very precious 30 minutes or 40 minutes or 20-minute time. In 20 minutes, you can be productive, being specific. And in 20 minutes, you can be absolutely non-productive of writing those things which doesn't have any relevance. I do not have any, I don't care. I am just concerned about what is happening to this patient with respiratory muscle once you have weakness. Is he able to breathe or not? What is the grade of weakness? Is he using? So if you could say that in inspection, patient has sign of respiratory distress with intercostal recession and using extra respiratory muscle, so patient need to be intubated. He was intubated. He has weakness and power of this thing. Your job is done rather than writing all this thing which is not relevant to me at present in this question. It had been
Yes, sir.
relevant to me if I wanted to know, I'm examining a MBBS student who is giving final medicine examination. He knows all this thing or not, that would have been relevant for him. It's not relevant for a student who is going for appear in DM critical care exam or equivalent.
Yes, sir.
Okay.
So gag reflex was absent and absent palatal movement on asking the patient to say ah. There was drooling of saliva was present and history of nasal regurgitation of fluid drinking. No movement of the neck muscles, could not protrude her tongue, and no restrictions in her eyeball movement. So after the provisional diagnosis, sir, we just intubated the patient and we saw the ABG. There was a type 2 respiratory failure and we intubated the patient in view of type 2 respiratory failure and bulbar palsy, and we shifted the patient immediately to ICU with ventilatory support for further management.
Can I ask you, if there was no ABG, would you have intubated this patient?
Yes, sir, we have intubated the patient.
But do you need ABG for intubation?
No, sir. Our patient is drowsy unable to speak, with weakness of cuff reflex, and patient is not moving all four limbs. So we will intubate the patient, sir, as soon as we have examined and we have come to our conclusion.
Okay, and can you interpret this ABG?
Sir, the ABG, sir, we have seen respiratory acidosis, primary respiratory acidosis, sir, along with metabolic compensation.
So adequately compensated? What should have been HCO3 if she's been compensated adequately? Is there any hidden disorder?
Sir?
Is there any other disorder or it's a plain respiratory acidosis?
So this is respiratory acidosis along with also with metabolic acidosis, because the bicarbonate is also not moving in the opposite direction of PCO2. So there is also, due to the dehydration or due to different reason, the patient is also having some component of metabolic acidosis.
So you should be like,
Non-anion gap.
yeah, you should write it there, because initially you presented, when you are writing the ABG in this kind of presentations, it's expected that probably you will write the what is the inference of that blood gas also at this
Okay,
level.
sir. Okay, sir. Okay, sir.
So what does it say? And one more thing, whenever you write oxygen, you should always mention how much oxygen patient is on, without oxygen or oxygen percentage. So that indicates, that's a very important
Yes,
and very
sir.
commonly missed thing. So if there's a respiratory acidosis, then ideally what should happen? Bicarb should go up or down.
Go up.
Go up, sir.
So it should have been how much up you are. What is the normal bicarb you are expecting? What is the normal we are expecting here? It is an acute respiratory acidosis or chronic respiratory acidosis?
Yes, acute respiratory acidosis. And already 48 hours had gone. So
No,
we
48
will be.
had gone for the 48 had gone for GB syndrome, not for acute respiratory.
Yes, sir. Not for the CO2. Yes, sir. So we will be considering, because the drowsy is
Let's
6 hours.
let's consider both. It is acute or chronic. What do you expect?
So in acute, 0.1 rise for every PCO2 rise. So for 0.1, so if the PCO2 is above 40, 74 means there is 34. So 34 into 0.1, that is 3.4 added to 24. So if it has been an acute, then it would have been 27.4 or 28. If it had been chronic, then it would have been 0.3. So 0.3 into 34, 9 or 10. So 24 plus 10, 34.
because ABG is very, very important in this when you are discussing particularly critical care context and you're presenting. Uh, very much focus will be on ABG, because if it is in hidden metabolic acidosis also, you have to think about
Yes.
what are the causes of that also, because your X-ray
Yes.
is showing right basal zone haziness. I'm not
Yes.
sure why MRI brain and MRI spine was done.
Yes, sir. Sir.
Why it was done?
MRI, sir, MRI brain was done to rule out possibilities of brainstem ischemia,
But
or
are,
to rule out.
is there any point in favor of brainstem ischemia?
So there is no upper motor and MRI brain.
Nowadays, I
See,
think
it was.
everything is done as a protocol. Neuro patient do everything imagine, so something should come out. But it's not a very, I mean, I will absolutely not like this if somebody mentions discussing about GG syndrome and doing MRI brain and MRI spine to begin with. I mean, it can be later on discussion, but it cannot be discussion
Yes,
in
sir.
this presentation. Like, and there are so, I mean, honestly speaking, if I start pulling your leg, you will be crying in today night. I don't want to make it. But I'm not happy with the general examination that you have written. Particularly respiratory examination is very poorly written. It has not been done. It is a totally disconnect. You have written as if you have not seen the patient. It's give me a feeling that you have not seen the patient at all. It has been written as if somebody, medical officer, writing the case sheet, and according to whatever you are saying is not correlating with the finding.
And the respiratory system, some SpO2 of 30 per minute, is this a typo error?
Whatever you are talking in this thing, I mean, honestly speaking, if you are doing same mistake in examination, you are failed here. Just with this finding. It cannot be bilateral basal equal sound. It cannot be rate 24 after intubation. It cannot be cough present, and then you are saying cough reflex absent. What we are discussing and what you are writing here is not matching. Or whatever you are writing is not matching with the clinical history of your patient, and that's where all the problem happens.
Rajesh sir, should we proceed?
Yeah, please proceed, sir. Kapil sir.
Yeah,
Rajesh sir, I think.
yeah. Please ask them, because I'm not able to see them.
Yeah, Arnab, can you proceed?
Yes,
Yes, sir.
Arnab, chill. We are discussing.
Yes, sir.
So chill. See,
Yes, sir.
basically, we are here to probably correct you.
Correct.
That is the way we should go ahead. So I will expect the next time you are presenting, I will better to have that chest X-ray also here, because just writing basal haziness will not do. You put an X-ray, so let people also see. People can comment, then they also can learn. We also can learn. Okay. Yeah. Next slide.
Yes, sir. Sir, with the patient was
Yes,
shifted to ICU.
I will tell you people that it's very important to correlate what you say. And if you are saying something which is not correlating, this is a catch point where you are caught in examination. So when you are presenting with respiratory failure, each and every finding should match, even if you are copying and pasting, because I have not seen the patient, but there is a discordance between what you are presenting and what you are saying. So this can't be discordant. It should be on same page. Okay, please go ahead.
So the patient was shifted to ICU, and on day 1, we have done a bedside focus examination. IDC
Why?
was 1.2,
Why?
sir, because to assess the fluid responsiveness
Was
of
this
the
patient in
patient
shock? Is this
as
patient
a
in
part
hypo?
of the no, sir, but as a part of the general examination, we have done a bedside focus.
What is more important as a general examination to do in this patient?
Sorry, sir.
What is more important as a part of general examination to do this patient?
General examination.
So general examination, sir, the CNS examination.
Sir, can you hear us?
Yeah,
Yes.
what is more important to do the examination? If you want to do echo or ultrasound, what is more important to do in this patient? I will do focus only if somebody is hypotension. Okay. I will do, I know the hypoxia is there, but if at all if you want to do, if patient has tachycardia, I should do echo. That what is the condition of heart? If somebody is hypoxic,
Yes, sir, we have done echo, sir.
No, what I'm saying, you are wasting a lot of precious time by telling the examination which are not relevant. That's what I want to say. So if you tell focus examination, it is more discussion. Like, why did you give fluid to this patient as a part of routine intubation, as a maintenance? Why the patient in shock?
Not in shock, but sir, the patient was unable to have the food intake for the last 2 to 3 days. Very poor intake. The patient was looking dry, and sir, there was a mild metabolic acidosis in our though the lactates, these things were not raised, and sir, the count was also on the higher side, and the BP, SBP, while receiving in the ICU was below 100. So we have given only 500 ml bolus, followed by 70 ml per hour. So for that reason, only we have done the focus. And as you
Why
said, sir,
Can I ask you one simple question?
yes, sir.
Do you agree this patient is in shock?
No,
This patient is in shock or not?
no, sir, this patient is not in shock.
So you feel BP 100/70, tachycardia, hypoxia, he is not in shock.
No, sir, for shock, BP is not always
What was the map?
right.
It was not mentioned anywhere. What was the map?
It was greater than 65. In the EF, it was greater than 65. We didn't start with any type of vasopressor.
No, I'm not asking about vasopressin. What kind of shock you will expect in GBS, and how will you differentiate? What are the different types of shock you can have in GBS on presentation?
So, in case of GBS, sir, patient can be hypovolemic, but that will not cause shock because there will be no blood loss. So, sepsis or infection can be there due to aspiration, or in the late presentation, any type of infection can be there. So there can be septic shock also. If the patient present is long-term bedridden, as you said, sir, earlier, hypoxic, tachycardic, hypotensive can have a obstructive shock also. So that depends on the type of presentation.
See, because if I'm at your place, I will consider this patient to be in shock. He has signs of metabolic acidosis. He has hypoxia. He has hypotension. He has tachycardia. He has shown signs of organ dysfunction. We yet don't know what is happening to other organs. So till the time I do echo and the rest investigations, my lactates, my cultures, or my other counts come, and I don't know what is the previous blood pressure to this young lady. I don't know what is her baseline blood pressure may be 140 by
Yes, sir.
80, nobody knows. So if I am at ER and I am the first man who is contacting this, I will consider this patient to be in the shock. So I will be justified to give this patient fluid challenge, which I agree with you, you have given fluid challenge. But the thought process would have been to raise the blood pressure, because the impaired sensorium drowsiness, what is the guarantee that that is not related to this hypotension? I will
Yes, sir.
definitely consider that cerebral hypoperfusion still can be the cause for this drowsiness. So probably giving fluid for this patient right up front has got utmost significance. And for that assessment of that fluid status, probably you can go ahead with focus, you can do echo, you can look at the lung. Now, if you already said on X-ray that your X-ray has shown right zone haziness, we would be expecting more in lung ultrasound. What is the right lung ultrasound shown? What is the left lung ultrasound shown? Or probably if you are targeting that that patient had aspiration. So I was expecting more in that lung ultrasound. So can you tell me what happens in consolidation on lung ultrasound?
So there will be dynamic air bronchogram. So there is a hepatization of the lung, and in consolidation we can see dynamic air bronchogram, and also if there is adjoining pleural effusion, that also we can see in the lung ultrasound.
So in consolidations, we can see B lines also, sir.
Why you didn't do CT chest for this patient? Anyway, you have gone for imaging for MR spine. I would have been very happy if I would have seen CT chest also. Would have given more insight about aspiration. Just a thought, because
Yes, sir.
looking at other parameters, look at the WBC count. Probably I will think, yeah, why I got this patient again to ICU. I would have done CT also. Just a thought.
Anyway,
sir.
anyway, are you justified in giving antibiotic to this patient? Because
Sir,
look, as a thing is okay, but when we are sure that we are dealing with somebody GB syndrome and need to intubate somebody for respiratory failure, which is predominantly of the primary respiratory, acute respiratory failure, and out of probably because that causes hyperdynamic and everything is explained. Once you intubated, gradually normalize her CO2 and to more focus on treating her GB syndrome. I mean, it's not, you are not doing any harm in giving IV fluid and doing ultrasound and all this thing. But what my focus is, again, you have a very limited time and you are wasting precious time. This patient who comes to you with rapidly progressive respiratory failure due to GB syndrome, where should be our focus? Our focus to be prevent the further deterioration and damage to the nerves and neurons, if the diagnosis is correct. So, apart from hemodynamically, your patient is stable, you have intubated, secured the airway. I will not argue too much on antibiotic that you have done culture, taken antibiotic, but I will not be in hurry in starting antibiotic to this patient because antibiotic is not going to do anything good for this patient. What is more important here? To diagnose, confirm your diagnosis.
To start the yes, sir. After confirming the diagnosis, sir, we will start IVIG.
No.
We will be
But
confirming our diagnosis. We will be confirming.
Look, even that's what I said. The moment clinically you have diagnosed, your presentation should be on priority. What I'm not saying you are doing anything wrong. The only thing I'm trying to say that you are presenting just like a MBBS or MD medicine student. You are not presenting like intensivist. You are dealing with a patient of acute, rapidly progressing motor weakness leading to respiratory failure. Your examination is not focused to that. I'm not saying anything you are doing wrong. Your focus is diluted and your focus is general. You are not talking with a focus clinician. So if you are dealing with, you need to handle respiratory failure, you have intubated. Now, how will you address the cause? Two things you have to address: arrest the development of further neuronal damage and prevent the autonomic dysfunction. Even the laboratory parameters which you have written on a priority, is something which is not mentioning. Day one you have done, but did you do CSF or not?
Yes, sir. CSF is also done, sir. Yes,
So
sir.
why it is so that CSF is not written first and is coming in sequence? Your sequence should be in a priority of addressing the concern.
Yeah,
We are
I
not going-
agree. Yeah, I agree with Rajesh sir, because the way you are presenting, you are just going away from your primary diagnosis and management of primary disorder, which has caused everything.
I'm not saying
Actually, sir,
yeah, you are doing in reverse order. Our priority
Yes.
is to arrest. So, like you are presenting CBC, you are giving us CBC. All these investigation is of no. I mean, CBC is okay, but right now it's not relevant to me. I'm not MRI, CT scan is not relevant to me right now. I have secured. I have taken history. This is my diagnosis. I want to rule in or rule out my diagnosis as a clinician. So while doing all the thing, examination, securing ventilation, I expect when patient is intensive care, his hemodynamics, his ventilation will be lung protective ventilation. You can say that, putting this and immediately trying to find the cause. That do not waste your and my time as a examiner or as a student, because you have 20 or 30 minutes. In 20-30 minutes, if you start discussing non-relevant thing, then I will not be able to discuss in detail about the current problem.
I agree with sir, because your priority should be like the primary disease diagnosis, which is your next slide should have been the first thing. Then the later on.
actually, sir, patient is.
I'm not interested in looking to this result also right now. It should be
Yes.
like that. I did general examination. These are the findings.
Yes.
These are my focus diagnosis. Based on the focus diagnosis, these are my findings. If examiner asks, did you see this, you can show I have done this. But if you start telling on front, like I have done this, I mean, it's not giving me any clue. It's just wasting my precious time, and I'm like, I need to go to sleep. I'm not focused to that. Anyway, you could have told after intubation sensorium improved, that is important find. After intubation heart rate improved, that is important find. That tells that your patient is not in sepsis. After intubation, this thing. Then the two crucial thing here: did you do CSF? When did you do NCV EMG? That's it. I'm not saying X-ray is not important. Post intubation, intubation done, X-ray checked, it's normal, tube in place, job done.
Okay.
I will not waste my time on doing ultrasound, CT scan, MRI, because each hour I am wasting on doing this non-insignificant thing. I'm not getting back to the focus thing. Each hour is wasting, his patient neuron is getting damaged. I need to find if it is a GB syndrome. I need to start either IB gamma as the emergency thing, or decide patient needs plasmapheresis.
Should we proceed, sir, to the next?
Please.
Yeah, now to the next slide.
Yes, sir. Nerve conduction velocity was done as per after consulting neurologist, and motor nerve conduction study of median ulnar and common cranial nerve posterior tibial shows normal distal latencies, normal amplitude, and normal conduction velocities. F wave minimal latency were absent, and CSF analysis was also done. Normal study with no albuminocytological dissociation was found, sir.
Okay, so probably you have confirmed your diagnosis on NCV and started on IVIG.
No,
Okay.
just wait. It is very important. So you are saying
Yes, sir.
NCP motor nerve conduction study of median posterior distal shows
Yes, sir.
normal latency, normal amplitude.
Yes, sir. Yes, sir. And normal conduction velocity.
So what are the then everything is normal.
But sir, FF latency is absent, sir. Yes.
Where it is written?
Sir, next line, sir. FF minimum latency is absent.
Minimal latency was absent. Okay. Sensory study was normal. Chest X-ray normal. CSF study with no
Normal, sir. No
normal.
albinocytology.
So
Yes,
why
sir.
why albino cytological dissociation was not there?
So because we did on the second day and we are not expecting on the
The patient has total 6 days of illness.
yes, sir.
Weakness within the first week, said this can be present and it cannot be present. So in 50 to 70% of the cases in the first week, it can be negative. It generally rises after day 10 and
Yeah.
Peaked at third week, sir.
What is more specific in NCB for diagnosing acute demyelinating polyneuropathy, ADM?
one is the increased distal latency. This is of the features of the demyelinating features, decreased velocity and increased latency.
Which
And
one
also, sir,
which one comes early?
So latency, sir.
latency.
Are you sure?
Sir, earliest, sir, we will see the absent of FOFs with absent of H reflex, and then, sir, we will see the latency, sir.
Is there any sequencing of the sequencing in NCB presentation, NCB depending upon the type of demyelination in acute condition?
If you are aware, you say, or we will move on to the next discussion.
Just try
In
to
the
look at if you do NCB in early stage, late stage, very late stage, what are the typical NCB findings? And which one is the most sensitive and specific? Okay.
Okay, sir.
So what happened next?
We're correct that albino cytological dissociation takes time to come, and that's why, but still it is for neurologists, it is sine qua non for diagnosing GB syndrome. So they prefer to it. And that is the reason they want that CSF to be repeated after 72 hours or may that just to label the diagnosis. So still CSF to be repeated. So you can say initial phase it is normal, but it can be high protein can be there later on. So we may repeat CSF after 72 hours. Okay.
Yes, sir. So,
Proceed.
sir, IVIG was started. So then we have started the DVD prophylaxis with low molecular weight heparin, and chest and limb physiotherapy was started, and rise to feeding was started, and IVIG was started.
Why did you give IV gamma? Why not plasmapheresis? Which one you will prefer?
Sir,
there is nothing superior, sir, IVIG or plasmapheresis, but it has been seen that the patient presenting within 2 weeks preference is for IVIG, and the patient presenting bit late within 4 weeks is plasmapheresis. And sir, as the plasmapheresis had some technical issues and availability and involvement with the other teams, so presenting within 14 days, we will go for IVIG. But there is no such clear-cut benefit one over another.
Anything else you want to do? Add?
sir, I would like to send a serum IgA level, sir, of the patient.
For giving plasma IVIG.
First, yes, sir. Before starting IVIG.
When you will prefer plasmapheresis? When you will prefer IVIG?
Sir, IVIG I will prefer when the patient is hemodynamically unstable, or the patient is in with volume overload, or when I am suspecting volume overload, or patient is hemodynamically unstable, I will go with IVIG. And if, sir, my patient is having some features like IgA deficiency or any features of thrombosis, risk of thrombosis, or anaphylaxis, or allergic to IVIG, I would go for plasmapheresis, sir. And
Plasmapheresis,
also based on availability. Sir.
Plasmapheresis with what? Plasma or albumin?
With plasma, sir.
Any other antibodies you do? You do some antibody
Sir,
studies?
yes, sir. I can do GQ1B antibody assay to rule out
Have you done
from variants of.
have you done in this patient?
No, no, sir. We haven't done it, sir. No, sir.
That is done in the Miller-Fisher variant. Sir, we have not done it.
Yes, sir. In Bickerstaff encephalopathy in Miller-Fisher variant, we can send it, sir.
Yeah. Any other?
You have given
Which-
IV gamma for 5 days. What is next?
Sir,
Sir, I will wait for
Go to
next
the
4 weeks.
Go to the next slide. Yeah. What happened next?
Sir, we have continued for 5 days. So day 2 IVIG given, patient condition continued same, no episode of fever. Hemodynamically, patient is unremarkable. Rise to feed in continued, chest and limb physiotherapy was continued, and EVD prophylaxis continued. And his and her TLC count subsequently came to lower, started to come lower range.
Next slide.
With your antibiotics. Total count started coming down with antibiotic.
Yeah.
Sir, cultures were, sir, anyway negative, so we were not sure.
Okay, okay. Go ahead.
Go ahead.
So day 4, 5, and 6, we have patient status remained same, and day 3, 4, and 5 of IVIG was completed. No episode of fever. Final culture reports were negative, and patient was tried for pressure support ventilation, but could not trigger the ventilator. So ventilation in control mode of ventilation was continued, sir.
Next.
So from day 7 to 12, there was no significant change in patient's muscle power, which remained 0/5, and patient could not trigger in pressure support. So ventilation in volume control mode was continued, and patient remained hemodynamically stable. Feeding continued. Bladder bile function was normal. No episode of fever, tachycardia, or hypotension. So we have discussed with the family, and we have planned for a tracheostomy for this patient, sir. At day discussion was done on day 12, sir. And tracheostomy was done on day 13, sir.
So why is your patient not recovering?
IVIG and 40 to 80% of cases, these patients require at least 4 weeks after the time to improve. And as the half-life of the IVIG is also 3 to 4 weeks, so we should wait for the patient to recover. If there may be some ongoing process which immunological process with IVIG cannot take over during the short period. We are given only up to day 5 and we are talking on day 7. So we need to wait for 3 to 4 weeks for the effect to occur.
Typical history usually from up to 2 weeks, sir, the disease process, then 2 to 4 weeks plateaus and start improving after 3 to 4 weeks.
So by the 4-week, patient will have a lot of secondary complication from ICU. So
Yes,
is
sir.
anything else you can do? Are you okay with waiting 4 weeks for the GB syndrome to recover?
Maybe they must be telling after what happened after 12th day. Do you want to present what happened after 12th day?
Okay.
Yeah.
Sir, we can
Proceed.
we have done, sir, on day 13, sir, tracheostomy was done on bedside with percutaneous method, and patient could not trigger the ventilator yet, so volume control mode of ventilation was continued on tracheostomy. No
But
clinical improvement was noted.
that is my only concern. Again, I'm coming back to case on day 1. Patient came to on 4 days. 4 days. Very late.
Yes, sir.
When present to with respiratory failure, you have to understand that patient has already gone into severe disease. I do not concur with your NCB finding what you have said. That's why I'm saying. It could not be only F-wave latency. Definitely patient will have, and if there is a tachycardia. So again, this finding is not correct of NCB MG what you have told. If somebody coming with tachycardia with such a rapidly progressive disease, causing respiratory failure, presenting to ER for intubation, that means patient has not only got neuropathy but axonopathy as well. And
that is what the neurologist has reported. We are to see that report, and it was repeated on the next day also.
It cannot happen that patient has only a wave latency with normal conduction velocity. It's not possible.
Yes, sir. We could have repeated the nerve conduction velocity after
Even
subsequent days to see.
even on first finding, it's not possible. And even on 6 day with such a severe disease with absolutely normal CSF is not possible. It can happen in mild to moderate disease, but you are dealing with a disease which is so rapidly progressive. If it have progressed over 7 to 10 days, it will not. But such a rapidly progressive disease with respiratory
Sir,
failure
actually,
is difficult
sir,
to
this
track.
is actually a real case, sir.
We have posted our printed reports in this.
Yes, sir. Actually, this is a real case, sir.
This
So
is a real case, and we are
I
still
mean,
following up the case.
I'm just trying to give you clinical importance of this thing. Okay, there was some discordance between what is done and what is if patient has this rapidly progressing. But anyway, if it was a predominant axonopathy, then your choice of treatment was not correct. If I would have been the treating doctor, I would have preferred plasmapheresis and prolonged plasmapheresis. If you patient had axonopathy, the result with IVIG is poor. These patients do not take longer time to recover, and many times after giving IVIG, we have to do plasmapheresis. So IVIG do not work that well if patient has predominant respiratory failure and predominant axonopathy to present with. The choice of treatment remains plasmapheresis. Plasmapheresis not with plasma, with albumin. Because by giving plasma, you are giving more antibody to this patient, more antigen to trigger. So plasmapheresis with albumin is preferred. These patients do not do well with 3 or 4 or 5 cycle of plasma. They need more, maybe 8, 10 initially, and they may be alternate day, because these patients have very high load of antibody. That's why they have neuronal damage. So if we try to focus in that direction to improve recovery, these patients recover well early. And many times they are able to escape from going on tracheostomy and extubate them on 12, 13 days and take help of an IV because they are able to protect their way. If you take it like give IVIG and do general care, most of the time these patient dies because of secondary complication rather than GB syndrome per se. So when we deal with a rapidly progressing GB syndrome with respiratory failure, our focus should be to wean them off early, to prevent the further neuronal damage, and that can be achieved good. And if patient is hemodynamically stable with plasmapheresis rather than IV gamma. I'm happy to listen anything you want to say. Anand and Prithwiraj. But most of the time,
I will ask only last question from my side. There are two things. One is doing antibody early in GBS is very important, because there will be a class of people where anti-GM1 antibodies are present. There is a clear-cut evidence that these patients do well with plasmapheresis. This is one. Second, so doing antibody later has no meaning. Try to do it upfront and try to prognosticate at the beginning. Second, questions to Arnab and both of you, that if I have to decide at some point of time that I have to repeat IVIG, so when it is to be done, or suppose somebody comes and tell me, okay, now you've done IVIG, patient is not improving, do plasmapheresis now. So tell me about these two scenarios, and maybe one question from Rajesh sir, and then we can conclude.
Sir, IVIG, sir, repeat IVIG, we can repeat after completion of 3 to 4 weeks. If we can see improvement in the patient, we can do repeat IVIG. But sir, in studies, no significant improvement has been seen, sir. And regarding, sir, about plasmapheresis after IVIG, usually, sir, we should not repeat up to 2 weeks because the already antibodies which we are giving through IVIG will be removed by the plasmapheresis. But sir, some studies have been done. They have done plasmapheresis after IVIG after 4 weeks. But as such, sir, head-on trials, nothing has been found that repeating IVIG after IVIG, repeating IVIG after IVIG, or repeating plasmapheresis after IVIG, there is any significant differences or any clinical improvement is found. Also, sir,
4 weeks to act. So repeating IVIG can be repeating the same therapy can be a process of thought during this time. So in the recent trial, which has been SID GBS in Lancet 2021, which was published. So in that trial, they have not found any improvement in the patient on repeating the IVIG, though they have waited only for 7 days and they have given a second dose of IVIG on the basis of MEGOS score greater than 7, which we use for the prognosis, but they haven't found any benefit in repeating the IVIG. Rather, they have found some important complication like thrombosis, pneumonia in repeating the second dose of IVIG. So though the trial was not perfect because they have I am not so big to say the perfect, but sir, as they have waited only 7 days before repeating the IVIG. So I will not go for a repeat dose of IVIG as per the evidence. And sir, what Arnab told, ki repeating plasmapheresis after IVIG do not have shown benefit in trials. Rather, it can wean off the effect of IVIG if done within 3 to 4 weeks. And sir, also switching to only the thing that if we see some treatment related fluctuation, means if the patient improve a bit and then again degrade by a GBS scale of 1, then only we have a scope to repeat IVIG or plasmapheresis, or if the patient is going to acute on CIDP, then we can thought repeating IVIG, but no such evidence is there of benefiting the patient, sir.
After 4
So
to
what I
6
will
weeks also,
suggest,
sir, if
what I will suggest, Arnav and Prithwiraj, I am not discussing here. I have said two things. Just listen to me carefully. I said that if it is a predominant axonopathy to begin with, I would have started with plasmapheresis because it is done more cycle, and it can be done more cycle, and recovery can be better with if patient has predominant axonopathy, and you can cut down the ICU stay. So there are paper and there are evidence for this. If you are giving plasmapheresis, the problem with plasmapheresis is that most of the time we see in axonopathy doesn't work well, and either to hasten the recovery with heavy heart, either we have to go for plaques, which is more of experience, or you have to repeat the IVIG, and preferably after 2 weeks, and maybe, or if you want to very specific, do the nerve conduction study, do the CSF. If nerve conduction is showing a feature of AIDP going to CIDP, you have to go for the alternate day or maybe weekly IVIG till your patient recover. So all these are I'm talking about recommendation. I'm not talking of my own. So I think you need to read further because we have taken you to a case where it's not a simple GB syndrome. It's a complex patient, complicated, not responding to IV gamma of initial dose. What are the alternative and how to approach? So if you go to search the literature by this heading, you will be getting your option. What we do in our practice, as I said, that if it is axonopathy, I defer to give IV gamma. I prefer to put the patient on plasmapheresis, and it has happened. Sometimes we have to do 2 times of plasmapheresis in a day because of the severity of disease and because of tolerance. The low volume be removed. And then once you go for plasmapheresis, once you stabilize your patient, you can do daily. After 5 or 6 cycles, you can go for alternate day. Look for the neurological recovery till patient neurological recovery can be assessed clinically, as well as if needed, you can do NCB study. Maybe repeat CSF will further guide you or patient is going in which direction. But if you have given IV gamma, we get stuck to see the effect. But most of the time, in 2 weeks' time, it tells us that a patient is not recovering. If patient is not recovering, either we repeat the dose of plasma regarding as a line of CIDP or maybe severe disease line, or we do plasmapheresis. We know that we will do plasmapheresis, will remove the gamma which is given, but giving that IV gamma which is not working for initial 7 days, 10 days, 14 days, it also doesn't work for 4 weeks also, that is proven also. So we do not wait now for 4 weeks for ICU, keeping patient on ventilator, him getting sepsis, pneumonia and dying because of that, rather than we try to work to rearrest or reverse the damage of peripheral neurons or peripheral nerves. Because if you are not able to do that, your patient is not going to recover. And AIDP is something like any other emergency. If you act early, you can reverse or treat early. If you delay in diagnosis and management and giving definitive medicine early, your prognosis and outcome is not good. Most of the time with this approach, AIDP is treatable disease, 10 to 15% you get patient who are not responding if you have not selected your medicine properly, maybe IV. So if it is a predominantly only conduction problem, no axonopathy, plasmapheresis is good medicine. But if it is the axonopathy where F wave latency is involved to begin with, plasmapheresis is not a good drug of choice. It's very specific. You can go and read. It's in literature. I'm not talking anything of my own.
Okay, sir.
We will be happy to take any question coming from the in general
Sir.
from.
Yeah,
Yeah,
Kaladhar, you can take questions if there are any.
yes, sir. Most of the questions are basically focused around the respiratory assessment at the bedside. Suppose if the patient comes probably in a stable state with the initial weakness, later progressing to respiratory failure, how can we assess, and when we generally take a decision that we have to go for intubation of that particular patient? That's what most of the questions being.
So intubation very straightforward. If disease is rapidly progressing, your extra respiratory muscle is weakening, and your one breath count is less than 20, and cough reflex is beat. That's one thing which they should mention, that when you are dealing with any respiratory muscle weakness, breath count is very important. That talks about your expiratory reserve volume. So if your expiratory reserve volume is less, can you just stop sharing the slide? We don't need to.
Yeah.
So
Yes,
if your expiratory reserve volume or residual volume is less, which you come to know by single breath count, then that's the time you have to intubate. As I said, that if your cough reflex is intact, patient can cough and you are getting only sign of extra respiratory muscle weakness, you can try with an IV to improve residual volume till you are, if you are treating patient definitely, because many times a patient comes too early, and by giving them appropriate choice and with NIV support, we are able to prevent the intubation also. But the intubation is a clinical decision. If you're not able to protect the airway, by the time you're getting hypoxic, is too late. If your saturation is dropping, this is the last thing it drops. The first thing in respiratory muscle dysfunction due to neurological cause, maybe it is myasthenia, maybe GB syndrome, or any of these. First, your CO2 start going up, and when your CO2 start going up, that can cause all kind of metabolic dysfunction, including tachycardia, shock, which can mislead to you for all the kind of problem. So we should not get into that, get trapped into that because of that. If you are very focused to that problem. So for CO2 care, supporting extra respiratory muscle weakness, an IV is good if cough reflex is good. Cough reflex means a patient is able to cough and protect the airway well. If cough reflex is not weak, just intubate the patient. Don't play with an IV in this patient. They will drool their secretion in the lung with the force of an IV, and you are gone. That you don't need to do that.
yes, sir.
So any other question?
Yeah, yes, sir.
I clear.
Yeah, Rajesh Misra, sir, always you have been tough examiner, as I can see. I think that is the best important thing, and
No,
it's
this
an
is the only
opportunity
time. This is the only
for the
time
best.
I can pull their leg and make them learn. I don't want to them to do the same mistake in the examination and going in this thing. So there's a basic thing which we took the case right from the basic to thing. But if anytime you are focused to your problem, not juggling around or not trying to deviate, your chances of success is high. If you are not focused, you invite problem for yourself. It always the rule.
Kapil sir, are you there? Yeah, Kapil sir.
Yeah, I agree with Rajesh sir. I think if you have to
Sir.
be very methodical the way we are presenting, and I think very interesting case, lot many new insights, and more focused probably as Rajesh sir said that the primary pathology that needs to be tackled should be, we should have to take examiner to that way what you want, particularly in critical care exam, because now we are beyond that MD exam. So the traditional approach of history, investigation, examination, and then treatment, probably we go like primary survey, secondary survey, ABC, and going ahead. I think probably that's the way we should be more like if we presenting in that way.
Yes, sir. Yeah. Venkat sir, do you want to add anything, sir?
Rajesh sir and Kapil sir, any role of this bedside spirometrics which are available has been seen to be used to check
Yes,
for the yes,
yes.
sir.
So, nowadays we are in era of objective medicine. Though single breath count is very good denominator to assess the respiratory muscle weakness because it directly correlate with the residual volume, expiratory residual volume or residual volume is directly and basically this residual volume goes down because your basal lungs are getting atlectic due to loss of the inspiratory negative pressure. So very good correlation with the single breath count. But if you have an objective parameter of the peak expiratory flow rate, objective parameter of doing PFT on bedside, which is the now clinical tool, you can do and ask the patient to repeatedly do it. So you'll be able to assess better way and objectively. But I still say the single breath count, if patient can understand and
Remains to-
repeat it, is the best to assess the progression of. If somebody asks me if I'm seeing a GB syndrome patient, myasthenia patient, or any patient with respiratory muscle weakness, and which one tool I will assess frequently, the single breath count. Most
True.
important, most clinically significant, and earliest it will, the moment it goes below 20, don't apply your brain. Try to do some intervention in supporting respiratory muscle, otherwise your patient is going to arrest.
Just to take it away from the case, sir, indication to actually admit these patients in ICU. Do all the GBS patient in any form, from mild, moderate to severe, all needs ICU admission on suspicion?
No, definitely not all. Any of the GBS syndrome, if they have signs of autonomic dysfunction that present with tachycardia, tachypnea, or anything, or signs of respiratory muscle dysfunction or respiratory failure. If patient has only GB syndrome, but respiratory muscles are not involved, they can have a good single breath count, they should stay in ward. So that's the denominator also. If you GB syndrome and it can in one breath, patient can count 30 or above, need to be observed in or monitored in ward if you have a very good monitoring system in ward. One means there are enough staff and people to monitor this patient and you start appropriate treatment. A lot of GB syndrome patients, in fact, recover of their own. They don't need it. In fact, 30 to 40% GB syndrome recover without anything. And another 30%, there's a 20% of the patient, 25% who needs to come to ICU. 60-70% do not need to come to ICU, either recover of his own or with the help of simple IV, IG and support, they get better on 5 days. If you have a lot of patients I know in GB syndrome who just came to me, we diagnosed very early. The weakness was in grade 3, not here. Patient was grade 5 weakness, 2 and 3. We started IV gamma from our clinic. By the time patient reached to hospital, she started already recovering patient. So it works that way. It's because we delay, and that delay causes severe neuronal damage, and that's why we'll end up in this kind of problem.
Rajesh sir, I think I was actually trying to follow and learn the case from the beginning. One point was clear that sometimes the cases can be a overlap, can be little atypical, complex, which may question our diagnosis. We make sometimes question that complexity there. Like in this case, we had so many things. Patient presented with CO2 narcosis, with directly presenting to the hospital in a state, all that. So this is not uncommon. And you've been talking about axonopathy and demyelinating variants, and then we have a lot of combinations. We say Aman variant, which is a purely motor, which is a motor and sensory, demyelinating. And these variants has also been linked with a situation of prognosticating recovery, a response to either a form of therapy, as you said. So what is your take? Once you do a nerve congestion study, you know what kind of variant it is. Is it a Aman, Asman, or it is a demyelinating variant? And how do you take a call? You made a very important point. If I have a axonopathy, probably I will directly switch to a
So
plasma.
I'm very clear in handling GB syndrome. The first thing is if I should recognize early, not waste too much of time in diagnosis. If clinical diagnosis GB syndrome, by the time this progress to upper limb, by the time it progress to neck and respiratory muscle is last to involve, I should be hitting it with treatment, either IV gamma or plasmapheresis, depending. Definitely, if it is a weakness coming, this means nerve conduction also will be down. quickly doing. I will not even CSF we don't do initially because we know for 7 days CSF is not positive. It's not.
May not be always
So
possible.
for approach is very clear. If it's clinical AIDP, which is predominantly clinically looks like, we go for a quick nerve conduction elasticity and showing conduction only affected. We go quickly for IV gamma is as fast as we can give it first dose. And then we repeat and monitor this patient. Most of the time, if you're given on this stage, they do not progress. But if patient comes to me, something like that with respiratory failure, with quadriparesis, respiratory muscle involved, and I need to intubate, I will definitely do the both CSF as well, because if CSF protein is high, that indicate that the protein, basically protein goes up because this extensive peripheral damage starts affecting the motor neuron, that is the motor neuron, and that release the protein inside CSF, and that's why protein start going up. Otherwise, in mild to moderate disease up to 7 days, you will not find anything inside the CSF. So, and inflammation. So, if I have done nerve conduction study and that clearly tells me it's a predominant only nerve velocity, that is the peripheral nerves involved, or exons are involved in different variant. If exons are involved, I will stabilize the patient, because once exons are involved, autonomic dysfunction also will be significant. You need to fill up this patient. Sometime you have to start adrenaline to stabilize the autonomic dysfunction. Noradine doesn't work. Basically, adrenaline works very well in this patient. Sometime in stress there, then we need little dose of steroid. After stabilizing, we prefer to start plasmapheresis. Maybe we may do 2 plasmapheresis in a day 1, 2, if it is a rapidly progressing fulminant AIDP. But preference is good, because I know if I give IV gamma, this patient is not going to get better and going to stay in ICU. So the approach we have changed this one, that preference we give, and there are enough evidence to say in this group of patient, plasmapheresis works better than IV gamma. We need to do higher dose plasmapheresis, longer duration of plasmapheresis. That's only difference it is. But most of the time we succeed in extubating this patient on 10 to 14 days and send them home by 3 weeks. So that's where our approach is
I
different.
think you're talking about one step ahead of categorizing, individualizing, specializing to the maybe target
Of course,
normal neuron.
we intensive for that only. We are not going to get normal walking patient is a neurologist, maybe a physician, maybe.
So,
Patient is only going to come to you when patient needs intubation. Still, your neurologist friend would not like you to interfere in decision. But whenever you get an opportunity as an independent consultant to work, at least you should be able to clear in your mind that what is good for your patient. Because at the end, they will say that my neurological part is okay, you are not able to wean. They will, most of the time, they do not accept that it's a neurology which is not recovering. That's why we are not able to wean. So our job is also to facilitate that as well.
the other component you very specifically were trying to point out, sir, the variant which we see, the typical variant. We don't see neurological involvement in most of our GBS variant, except maybe when you have a brainstem encephalitis. That's what we call where this is an involved, and maybe the other variant where that is, as you said, the myasthenias mimic, like when you have a cervicobrachial or bulbar weakness which is involved. So in this case, we do understand probably it looks like a quadriparesis, respiratory muscle weakness leading to CO2 narcosis. But sometimes this is all confusing. Somebody presents to us, we all understand GBS, we see the patient conscious, and the patient die either because of a dysautonomia or because of either a tube block or anything. They most of the times, otherwise they will be conscious, awake, listening to you and all. So in that way, if we have come across any of a Becker-Steph encephalitis or variants, then their confusion starts. A typical progressive ascending symmetrical paralysis with a typical presentation, as you said, is a easy diagnosis for a neuroclinician, and we will be just a bystander for a probably evaluation and a supportive care or just a monitoring. But in those situations, if we come across, that's a bigger challenge for us, sir. Then what will be our call? See, most of the presentation will be also completely different. Patient sensorium is involved and others. So do these antibodies help there?
So let me tell you very clearly, GB syndrome is a diagnosis to rule in and rule out, both. You have to confirm diagnosis, and you have to also see that there is no atypical variant of GB syndrome. Atypical variant means only pharyngeal muscle involved, only eyes involved, only brainstem involved, or isolated nerves are involved, isolated only respiratory muscles are involved. So all these need to be diagnosed. That's why you do all the battery of tests to rule out. You rule in by doing CSF. But suppose you have done first week or second week also you don't have cytoalbuminic dissociation. There a diagnosis is in doubt. If you do only CSF, if you don't have nerve conduction velocity affected at all, your diagnosis is in doubt. So you have to rule in and simultaneously rule out other diagnoses. Same, like say example, snake bite, particularly the cobra bite, can typically present like this only. Typical respiratory failure, all muscle weakness. So in that you will not find CSF involvement. CSF will be normal. You may not find bite history. I know
Crate bite, yes. Crate bites, we will not find any marks also.
I know 4 patients in my entire career who has been declared dead on 8th day.
Brainstem dead or dead.
And declared dead kind of thing. And only thing heart it was working and with typical history. The history was very typical. They were sleeping in night time on ground and they got up and they were respiratory failure and they came to the hospital. And by the time they intubated and ventilated, and because of secondary thing, they had weakness. And on 8th they gave anti-snake venom and that child got up in next 12 hours. So anything can happen. That's why you need to rule in and rule out together thing. So even if you are treating with GB syndrome with nerve conduction elasticity, but you need to do a CSF repeat, that you are not missing something in diagnosis. Brain stain, meningitis, and encephalitis with thrombosis, secondary complication can typically present like this finding. If you have CNS, so I cannot pinpoint, but what is more important, keeping your patient safe. Patient has come with respiratory failure, intubate and secure. Patient hemodynamically unstable, stable issue. You wash out CO2. If you think that this respiratory failure has caused unconsciousness, it has been acute, you wash out CO2, your patient should be alert and conscious.
Alert and conscious. Is that happened in this case?
If it did not happen, that means there is some other reason causing unconsciousness. If your patient was having metabolic acidosis, because primarily of LGBS and respiratory failure, which is can counter happen because once CO2 goes up and if it affects vasodilation, tachycardia, that affect renal perfusion, and that paradoxically can affect the. So moment you wash out CO2, manage the moment you maintain hemodynamics, in 2, 3, 4 hour patient ABG should be okay or normal if you washed out. If that doesn't happen, that means so for whatever you are thinking, if you are not focused, you will not get the cause. You need to focus,
True.
okay, GB syndrome causing respiratory failure, I washed out CO2, and next 6 hour, 8 hour, 10 hour,
Patient should be awake.
Should be normal, hemodynamically should be stable. Tachycardias will not be stable, blood pressure may fluctuate a lot. These are
The sensorium should be recovered.
these are indications that you have autonomic failure. As far as you are talking about the variant of GB syndrome, there are multiple that can be focused, isolated, or generalized. That's why all the diagnoses of GB syndrome, myasthenia, transverse myelitis, Miller-Fisher syndrome, only myopathy, girdle myopathy, everything comes in differential diagnosis. But they have a specific thing. When you, that's why there is a criteria to diagnose GB syndrome. Onset, progression, nerve conduction. Nerve conduction comes later than cytoalbuminic dissociation. But nerve conduction is a new, when criteria was made at the time, it was not that prevalent. That's why cytoalbuminic dissociation was important. But now we know that doing early nerve conduction elasticity, you can pick up diagnosis early and prevent the progression of the disease. So
True.
you have to keep on thinking. Somebody is raising hand in the group from the chat box.
There are many questions in the chat, sir. I think we covered most of them.
We covered
I
most
think
of
the
Yeah.
Anything
the-
specific we can discuss, otherwise fine.
The students are most of them are-
I'm not that expert in treating GB syndrome. I have my limitation. I'm not a neurophysician.
No, sir. It's
But
a
these are ICU related issues are
yeah,
very
exactly.
my heart.
See,
That's why
the whole discussion is related to more of intensive care management of a GB syndrome than neurology point of view going into micro. Anything from Arnab and Prithwiraj?
Yeah,
Sir,
I agree with Rajesh sir, because when you are managing GBS in ICU, your thought process of something bit more should always be there right from the day one. And unless we think about something bit more, most of the time it doesn't happen that we are so lucky to get so straightforward case. As Dr. Venkat has rightly said, there'll be always something which is hidden, will be popped up. So you have to think about that right from the beginning. So we always prefer to send those all antibodies upfront, because recently I had a similar case. I would like to quote that presented with classical GBS, day 5 to be Zika syndrome and developed renal dysfunction later on, and was proved with all the antibody titers and NA blood, and patient's potassium later on day 6, day 7 went into hypokalemia. So repeatedly we were analyzing why suddenly patient got into hypokalemia. So patient had developed Sjogren's, and that was the entire hypokalemia was due to Sjogren's. So that was an overlap of Sjogren's with GBS, which I have never seen before. But we all the time we are keeping our mind open that why this patient is not improving.
Ideally, when you have treated it well, they can choose. There is a disease pattern with the medication, and if your patient is not following that pattern, it's a simple rule: come to the bedside and ask again what you are missing.
What is it? Yeah,
And
revisit.
and if you do not ask yourself that if you are missing something, you will not find it. It's as
True.
simple. So if any of your patient who should be typically following a pattern of the disease with the treatment, if that is not happening, you keep on looking to that, but not at the cost of harming the patient. You should not be doing some funny investigation just to see that you know this much. You should be, whenever you ask for any investigation, there's another funniest thing which we have a little bit of the discordance with the people who deal with chronic medicine physiology, that they order some funny tests which do not have any relevance just for the saying that they know so much. So if you are asking for any investigation or report, think for the cost and think for the what is going to change the treatment.
Therapeutic implication
Yeah.
of that.
If some investigation is going to change your treatment in sick patient, then do it. If it's just doing for fun, or for fun means not typically fun means
Just
just
to
trying
show
to
up
show your
your
knowledge, it's not appropriate. If you are doing some investigations, do it. That will change your treatment. Otherwise, don't do it. Many times sitting back and just watching and maintaining hemodynamics does a lot of good thing with the patient rather than doing something which harms the patient.
Yeah, over to you, Kaladhar.
Yes, sir. Thank you very much, sir, Dr. Rajesh Misra, sir, and Dr. Kapil Borawake, sir, for sharing your clinical insights and expertise. It was an extensive session, and thank you, Venkat, sir, for guiding through. And thank you, Dr. Arnab and Dr. Prithwiraj, for presenting that case, which caused an elaborate discussion, and I think very useful.
Dr. Arnav and Dr. Prithviraj, see, many times we face this real-time challenges, as you mentioned, and we wantedly have some seasoned senior clinician, Dr. Rajesh and Dr. Kapil Borawake. What happens in exam also, you get a spectrum of different clinicians with lot of wisdom, lot of experience, and so this is an exposure to actually make yourself prepared for your exam. So Rajesh sir, any clinical guidance that how do we, as it there are hundreds of students waiting to listen to you, examiners like you, when they come with lot of experience, clinical acumen, lot of hands-on papers which has been gone through. So how do you want them to handle them? So this is a particularly master classes where the students would get the tips at the bottom.
So for look, first thing, although all of us try to read for preparing exam, honestly speaking, when we try to learn, we try to make our basics clear. As I said that there is so much of the discordance in finding
Yes.
what you presented and what the case looks like. That really expose you that either it is not by you or somebody else has written the finding who doesn't understand the importance of the finding. The first thing is whatever you say, it should correlate with what you are saying. If you are saying something clinically, your clinical finding observation should match to that. That is the most important. Keeping basic right. In examination, you really don't need to show your knowledge. Just keeping simple. And in fact, in general in life also, if you keep the things simple and basic, you will never fail. When you make the thing complicated, then only problem happen. And most of the time, those people make complicated things complicated who do not understand the importance of simplicity. So if you are keeping your things, basic things right and simple, nobody can do anything with you, because that is the most toughest job to do it. So always, whatever, like clinical correlation, whatever you say, I mean, I'm not talking about the clinical medicine. I'm talking about the whatever you say. That if you are saying that patient came to you with a sign of respiratory failure and quadriparesis, and if you are saying respiratory rate is normal without any change in the pattern or extra respiratory muscle, who will trust your finding? So this, each word you say in examination should have a clinical correlation in your finding. If you do not
Absolutely.
correlate with that, that's where you are stuck. And the people who correlate it well, they are through. It's simple.
So these are the, I think, the words of wisdom that the two important points which he emphasized. One is whatever case you present, you keep on looking at the correlation and justification for why you are doing and what is the link to that. So if there is a discordance, is probably there where the examiners can pull, because most of the times you may not be having a detailed clinical examination at the bedside. They pull out from your own information and try to link them. So any comments from Dr. Kapil?
Yeah, as Rajesh sir said, probably while presenting something called editing. I'm not saying editing means something which is not there. Editing means wisely presenting the relevant points to the examiners will fetch probably more insight into your case, and probably examiner will get to know that you know what is to be said and what is not to be said. And that is also very important points, and that can lead to your discussion at the correct way, rather than if there is a discordance because they are bored with same pattern of exam, suddenly somebody utters something different, so they'll be very happy to take your exam to that lead. So I feel
Okay.
that correlating is very
In fact, I will say Venkat and Kapil is also mistake from all the people who are sitting on top, that they have never tried to tell students to change the pattern of the presentation. They have never told the student to be focused, discuss what you are supposed to do, not to give irrelevant information that kills the time. And this thing we have started learning, Venkat. I mean, I'm also learning and still learning. They started learning when we started writing papers for international paper, and then we came to know, like, my God, what we do and what should be done. So I think if for today's discussion, if people can go with one thing, one wisdom, that being talk less, be focused, talk that much only which you know, is the root cause of your success. Don't try to show your knowledge. Nobody is so knowledgeable in this world that he knows everything. So,
And you made a very important point. Try to stick to basics and allow the examiner to ask you the leading so that you take one after the other. That's the better way.
and whenever you give information which is not relevant, you are opening a Pandora box of irrelevant discussion and killing your important time, and your case will not be discussed. It
Yes.
will not lead to conclusion, and chances of you getting fail is higher.
Thank you. That's absolutely. And these are the learning points, and you both will do well. We are all best wishes. This is just an experience so that we all get learned from each other. Over to you, Kaladhar.
Yes, sir. Thank you, sir. I think with that, we'll close the session, sir. Thank you very much.
Thank you. There was a good attendance. It is all Rajesh Misra sir's
Yeah,
presence and Kapil sir's presence.
your cases are so popular. It's nice that people learn from
No,
that.
sir. This is a active sessions where there are 200 comments on different discussions. They are actively involved. We see some other country people, and we see around 5,000, 6,000 views in a day, sir. That's how these cases reach. So these are all experiences you said, sir. That's how all our senior colleagues, faculties, which come and be a part of this to teach all of us. That's where we are able to do, sir. Thank you very much for being us. Thank you. We conclude the session.
Yes, good night.
Thank you, Kapil
thank
sir,
you, Venkat.
and thank you very much.
Very nice session.
Being also on the scheduled travel, you try to accommodate us. Thank you, sir.
Yeah. Good night.
Thank you.